This is not in your textbook, interestingly enough. And, you know, this is one of those subjects, these topics, that I wish somebody would have just explained it to me when I was learning, because it has always been so confusing to me. And so I just want to take a few minutes to talk about this and actually explain what the heck it is to you guys, because when I first started learning this, I thought it was just all the same. This congestive heart failure thing that we just talked about, and this new concept known as cardiomyopathy. Let me put this up. Cool. I kind of just thought, hey, cardiomyopathy, well, what does that mean? Well, what's cardio? Yeah, so cardio is heart, myo is muscle, and pathy is disease. So it's the disease of the heart muscle, right? Well, what's congestive heart failure for the most part? It's a disease of the heart muscle, right? Oh, cardiomyopathy and congestive heart failure, same thing, right? No. And it's somewhat subtle and nuanced, but here's the difference. When we say that somebody has congestive heart failure, what do we typically mean with CHF? CHF is the result of what? Ischemia. It is secondary to ischemic heart disease, to cardiovascular disease, to coronary artery disease. Does that make sense? It is a secondary, CHF is a secondary problem. Does that kind of make sense? Cardiomyopathy, however, is a primary heart muscle disease. It is not related to ischemia, okay? But to make it more complicated is cardiomyopathy presents like congestive heart failure. These patients present pretty much the same. But what differentiates a cardiomyopathy from congestive heart failure is the pathophysiology. What's causing the disease? What's causing the congestive heart failure-like signs and symptoms? Are you guys okay with that? So CHF is secondary to other pathologies such as hypertension and coronary artery disease. Those are the two most common causes of CHF. A cardiomyopathy, however, is caused by much different things. And the main causes of cardiomyopathies, this should come as no surprise, are going to be genetic disorders. Genetic disorders that result in alterations in muscle. Okay, often they result in the buildup of abnormal proteins within the heart muscle that causes a dysfunction. So some disorders are amyloidosis. Okay, amyloidosis is a disease where you have what are called amyloid protein plaques that can develop. And this can develop in the heart and other organs, okay? Sarcoidosis is somewhat like amyloidosis. So sarcoidosis is the development of plaques, okay? And this isn't necessarily isolated to just the heart. It can be the lungs as well and other organs. Hemochromatosis is a genetic disorder where you end up having too much iron, and that iron can get deposited in organs such as your heart and your liver, particularly. And then there are all sorts of disorders, and we just kind of collectively call them inborn errors of metabolism. Okay, these are defective genes that code for enzymes and certain metabolic biochemical processes. Okay, how we manufacture certain proteins, how we break and build, anabolize and catabolize, and this can result in abnormal muscle function. You guys okay with that? Now, some other causes are myocarditis, particularly viral. Somebody who develops a viral myocarditis, okay, for reasons that aren't well understood, they can develop cardiomyopathy. Toxins, particularly ethanol. Okay, chronic ethanol, ETOH, which is also known as drinking alcohol, right? Okay, drinking alcohol. Pregnancy, interestingly enough. a certain number of people who get pregnant will go on to develop cardiomyopathy. We don't know why. We don't really have a... Siri was looking up cardiomyopathy. He's listening to me. Shut up. All right, get back to the task at hand there. Yeah, shut up, Siri. You're not wanted. All right. Anyone like, you ever have a bad day and you're like using Siri to find something and it doesn't work? You're like, oh, you stupid, and then you feel bad and apologize. I've actually done that a couple times. Like, oh, I'm sorry, Siri. I'm apologizing. Yeah, I'm personifying, right? I'm personifying my technology. Yeah. Okay. Who knows? Maybe it's only a matter of time before the lights go on with our technology, and then. But anyway, we don't know. We don't know why some people that get pregnant develop cardiomyopathy, but it is a problem. And then, believe it or not, a very common cause is this. What's that mean?
No idea why.
Who knows? Yep, idiopathic. A lot of things in medicine are going to be idiopathic. And like we talked about earlier, toward the beginning of class, you guys have to get comfortable with the unknown, because that's where the cutting edge of medicine is the unknown. There is a lot of stuff that we don't know. In fact, when we look out into the universe, like almost 97% of the universe is unknown to us. I don't know if you guys were aware of that or not, but when we look out into the universe and we look at what's going on with the universe expanding and all the mass that we see out there, most of it is stuff that we can't account for. And we call this stuff dark energy and dark matter, quote unquote, but we have no idea what that stuff is. And that comprises about 96, 97% of everything. And only a couple percent of everything is the matter that we know, the atoms and the particles that make up the atoms, the molecules. Isn't that crazy? So we have to get comfortable with the unknown in healthcare, as well as just pretty much everything else. Just get comfortable with saying, I don't know. That's a powerful thing to realize. But anyway, so there you go. All right. So I want to talk about the three major types of cardiomyopathy. And these are dilated, hypertrophic, and restrictive. So in dilated cardiomyopathy, what happens is the chambers of your heart become enlarged. They dilate out. And what does that mean to the muscle? Well, it kind of means that the muscle thins out, in essence, quote unquote. So the chambers dilate, they get really large, the muscle thins out, and what do you suppose that does to your contractility? Decreases. And so this is a primary systolic failure problem. Dilated cardiomyopathy is a systolic failure. How do these patients present? Just like CHF. Heart failure, pulmonary edema, peripheral edema. What is ascites? Fluid buildup or retention in the abdomen, right? Yeah. Ascites. Good. All right. The next form of cardiomyopathy is something known as hypertrophic. And what's hypertrophy mean? Good. The heart muscle undergoes significant hypertrophy. This is not due to hypertension, though. Remember when we talked about diastolic congestive heart failure? This is not due to chronic hypertension. Okay, this is often due to genetics. It is often due to pregnancy toxins, okay, various genetic disorders, but it is not due to hypertension. It is not a secondary, it is not a problem that is secondary to high blood pressure, like we would see in left ventricular hypertrophy of congestive heart failure. Does that kind of make sense? All right. So what does that mean? Well, you have decrease in filling and outflow of the blood. Okay. You can't fill the heart up. And this leads to heart failure. But an interesting thing occurs in hypertrophic cardiomyopathy. Okay. Valsalva maneuvers. What's a Valsalva maneuver? Yeah, that's your vagal, right? That's your typical vagal maneuver. Bear down, cough, okay, can actually make the signs and symptoms get worse. So Valsalva maneuver may cause the signs and symptoms to get worse in somebody with hypertrophic cardiomyopathy. Okay? And then finally, we have what's known as restrictive. Okay? And this is due to fibrotic changes and abnormal proteins infiltrating into the muscle, such as what you see with amyloidosis and sarcoidosis. Okay? Abnormal proteins come in and infiltrate that muscle. It becomes fibrotic and scarred. Okay? And what happens? Well, it becomes stiff, right? Does that make sense? The left ventricle becomes very stiff and scarred, and it cannot fill properly. And so this is classically presents as a diastolic failure. Okay? But what about your ejection fraction? Is it going to be normal or abnormal? It's going to be normal, right? If you have a stiff ventricle, does the ventricle generally contract well? It contracts well, it just doesn't fill well. Does that make sense? Fill as in F-I-L-L, not feel. You can't fill it, but you can get blood out of it very easily. So this is a case, again, as we talked about in diastolic congestive heart failure, where your ejection fraction is going to be normal, but your overall stroke volume is going to be lower than normal. Does that make sense? And this is a diastolic problem because it's a problem with getting blood into that ventricle. You guys okay with that? And then ultimately, these all present very similar, heart failure, and we already talked about the major causes of cardiomyopathy. So let me ask you guys the question. Are you okay with the difference between congestive heart failure and cardiomyopathy? So CHF proper and cardiomyopathy. You guys okay with that? So it really just comes down to the pathophysiology, well, the cause. The signs and symptoms are very similar. The pre-hospital treatments are going to be very similar for the most part. Okay? They are clinically indistinguishable, right? When you do your physical exam, clinically your patients are going to present very similarly, but there's some different pathophysiology going on. And so cardiomyopathies are going to be diagnosed a little differently in CHF, right? And certain types of history will push you toward the diagnosis of a cardiomyopathy. If they've had a history of viral myocarditis, if they have a history of being pregnant, if they have a history of some of these genetic disorders, that will push you more toward a cardiomyopathy than, say, a 62-year-old male who's obese, has uncontrolled hypertension, has a history of diabetes, and had a myocardial infarction 7 years ago and has 2 stents. That's somebody whose history suggests your CHF route. So does that kind of make sense there? What's going on? Now, in a lot of cases, what is going to be a very important test that's done in the hospital on these patients? With both CHF, huh?
The cardiac enzymes?
Well, cardiac enzymes are for acute coronary syndromes, right?
Right, well, that's a differentiator between the two, right? Because if it's CHF.
Okay, yeah. Yeah, but I'm talking kind of going beyond the standard tests that we've already talked about, and like how can we really dig down into what's going on with the heart and how's blood flowing through it, and how do we get that though? How do we get all that information in the first place? How do we even find out what their ejection fraction is? Like what is done to figure that out? Well, the angiogram is more about the coronary arteries, right?
Stress test?
Well, a stress test is you just stress the heart out and see if you have ischemia, right? So you hook somebody up to a 12 lead, you run them on a treadmill, and if their T waves invert or they have ST elevation, that tells you something about what's going on with their heart. Or you give them a drug like dobutamine that increases their heart rate and stresses it out. But that doesn't really tell you how blood is flowing through the ventricles and how the valves are working, and what really allows you to dig down and look at that. say, so
Echocardiogram?
echocardiogram. An echocardiogram is going to be a very important part of working these patients up, right? And finding out, okay, what does a ventricle look like? Are they dilated, right? Are they closed off? Are the filling volumes slow? Is blood having a hard time getting in? Is not enough blood getting pumped out, right? And that's actually where you get your ejection fraction. That's where you determine your stroke volume, is by looking at blood flow through the echocardiogram. And the good thing is it's non-invasive, and it can often be done right at the bedside in the emergency room. So that's a very important test in working somebody with CHF or suspected CHF or some sort of suspected cardiomyopathy up. Not so helpful out in the field, right? But again, you know, where do we see paramedics working nowadays? Everywhere, right? In all environments. In the hospital, outside of the hospital, okay? In the home healthcare environment, in the community environment, in the rural environment, in urban environments. And so you guys are very much becoming generalists. Used to be that a paramedic was a very esoteric kind of occupation, right? There was a very specific area that you really cared about, and now what we do, what we know is becoming much broader. Hence the reason that I wanted to talk about some of these other issues, even though they're difficult to assess or to really nail down in a clinical sense without all this other stuff attached to it. But, you know, hey, who knows? You guys may end up in an ER. You may end up in a cath lab. You guys know Brad Davidson? He spent, I think, almost a decade of his life working in the cath lab as a paramedic. You know, so there are lots of different options that you guys may possibly find yourselves in. You go okay with that, though? Does that kind of make sense? Cool. All right.